off. So welcome to the February QHOC Quality Health Outcomes Committee meeting. Just a few reminders that are on our tips for meeting participation. Please remember to keep your line muted when not speaking. When possible, use the raise hand function, which is under the reactions button on your Zoom panel. If your phone is not allowing you to talk, you could always try and *6 to unmute yourself. Also, if you can remember to say your name prior to speaking, that will help to ensure all parties know who is speaking. So again, my name is Lisa Bowie, Quality Improvement Director for OHA. We'll go ahead and get going. Jeannie or Doug, do you have any announcements before I go into the updates that we have?
I do not. Doug, do you have any?
No.
Great.
I think we're good, Lisa.
Okay, let's go ahead and advance to the next slide. There's your Zoom tips. Next slide. And next slide. Okay, we have a few things left over from the previous meetings and just some general updates. So the ORAC, Oregon Resource Allocation Advisory Committee. This is a committee I'm helping Dr. Dana Harganani, our Chief Medical Officer, with. This is the committee that will be a broad partner group open to all the community, in which we are accepting applications until this Friday. That committee is ultimately going to be the group who reviews our existing interim crisis care guidelines tool that was released in early January. Also build upon the equity principles that were released in December 2020 for COVID, and then look at other states' crisis care guidelines. So if you know of any interested party in your communities, we are still accepting applications. And just of note, we have a lack of applications submitted from the Southern Oregon and Eastern Oregon regions. You can always reach out to myself if you need more information. And you all should have this outreach from me in prior emails. The just a reminder, if I could put lines on mute, thank you. One of the questions that came up from our chairs that we did get some additional information, and we wanted to make sure you all had that, was a concern from that was expressed by the chairs to Dr. Don Mottner, Medicaid Medical Director, and myself, was, hey, we've heard of some facilities who might not be accepting patients due to negative COVID testing or lack thereof. And so what we have provided you is the best practices for hospitals and long-term care facilities for COVID-related new admissions and readmissions and discontinuation. So if in fact you are hearing in your community any particular, I think I got muted. This is Lisa Bowie again with the Quality Improvement Director giving you your QHOC announcement. So if you hear about any particular SNFs or long-term care facilities in your region who you're wondering if in fact they're not receiving patients according to the best practices guidelines put out by the state, then you have this as a reference. And then additionally, if you are alerted of any of that and there's still kind of issues, then you'd want to raise that up to Dr. Don Mottner, and we can appropriately connect within the authorities within our COVID response unit. But they wanted to make sure you had this because this is what is being communicated to hospitals and long-term care facilities. I'm going to pause there. Jeannie, Doug, Don, anything to add? Okay. And then the last, there's two more updates. One is just making sure everyone's aware of the CCO weekly update. This used to be known as the email that came from Dave Embody every Friday. It has transitioned to an actual, what looks like a newsletter form. It's known as the CCO weekly update. There's a whole host of rich information in that. If you are not subscribed to that, then please let me know. Oftentimes we have a lot of information that goes from CCO Ops Collaborative, CCO Behavioral Health Meeting, CCO QHOC, us in this meeting, and you'll want to make sure that you'll get kind of the written, most up-to-date information as well through that weekly update. It also includes your COVID immunization kind of data, so you'll see that as well. Some key specific updates I wanted to bring to your attention that we've talked about in this meeting and make sure you saw it. And again, if you are not subscribed, please let me know and we'll connect you with the right parties. One of them is in the January 21st update. It includes guidance about texting and emailing members. Specifically, this came up during the CCO medical directors in the summer, post the heat dome. And we were talking about solutions as far as how we can connect with members. One of the conversations was around kind of the guidance around texting. So there has been that guidance put into January 21st. Another one is around therapeutics and pharmacy coverage for COVID. So that's in the most recent one, February 4th. So please look in the CCO weekly update for that. If there are any, again, follow-ups, there's specific contacts within each one of those kind of topical areas within that update. So really important for y'all to get connected into that. The last update I have is for QHOC. We are going to have the support staff who helped me with this meeting, Michelle Hatfield and Jennifer Bowen. They're going to be resending out the appointment series. The reason for that is we're going to follow OHA's wellness policy, in which we all are living in this virtual world, many of us in these meetings. And so OHA has instituted a wellness policy and starting meetings about 5 minutes late. So the meetings will begin at 10:05. It's allow kind of that transition period instead of going literally meeting to meeting and clicking Zoom link or Teams link, you know, every 30 seconds or every 30 minutes. So we will be updating the QHOC appointment series to begin the meeting at 10:05. And you'll see those Outlook appointments coming shortly into your inboxes. Any questions, updates? And I see you all putting in there. If you aren't getting the CCO weekly update, I'll look at the chat string as well, or you can email myself, Lisa T. Bowie, and we will connect you. I am actually heading off because I'm not feeling well, but I was the houser of the announcement, so I wanted to come and join you all. Dr. Dawn Mottner will be here to facilitate the morning, as well as your chairs, Doug and Jeannie. And then for your learning collaborative, we have our a consultant who will also be assisting with the learning collaborative. So you guys are in good hands, and you all know you can email me, but I will be probably offline for the next few hours, maybe day. Anything else before I head off and you guys all carry forward without me? Dawn, you're on mute. So hopefully it was, you know, really important stuff. Still on mute. Okay, Dawn's going to figure out how to go off mute. We'll go ahead and advance the slide. I think we're going straight into COVID updates. So Dawn really needs to figure out how to get off mute. There you are.
Okay. Good morning, everybody. Dawn Moutner, she, her, Aya, Medicaid, OHA, OHP Medical Director, and appreciative, Lisa. If there's nothing else from you, then I hope you feel better and get some good rest. And thank you for joining us this morning. Doug and Jeannie, was there anything else before we move into COVID updates?
Nope, I think you're good from my end.
Proceed.
Okay. This morning, I won't share much because we have Dr. Kristen Dillon here presenting a good deal of the epidemiology, hopefully some good news coming down the pike. Cross your fingers and keep masking for COVID, and Dustin Zimmerman to supply us with some information. Kristen, are you here? I'm not hearing her. Does anybody see Kristen on right now?
I don't, Dawn. I'm not able to see her on there.
Okay. Why don't I start to take you through some of these slides? And if Kristen shows up, she'll say smarter things about the slides, but they're pretty self-explanatory, a lot of them with the epidemiology. Next slide, please. So as you can see, our 7-day average is starting to come down in a way that suggests that we may be getting a hold on Omicron, due likely to both vaccination and community levels of immunity from infection. Next slide, please. All right. As you can see, there was a whole lot of testing during January. The amount of that is starting to come down, but more importantly, the percent positivity is decreasing, trying to get back toward that 5% level, which describes what it looks like when we are hopefully doing enough testing to pick up most of what's out there, and also maintaining our contagion levels with whatever the interventions are at that time. So the decreasing of test positivity, percent positivity, is a really good sign. Next slide, please. So the proportion of people who are in the hospital, who are in the ICU, and the proportion of people who are hospitalized here is what we need to be looking at. And I am looking at the number of people in the ICU, but also the percentage in the ICU. That seems to be coming up, and maybe it's plateauing a little bit. We'll have to see how that one plays out. As you know, the hospitalization is a lagging indicator after the number of cases by roughly 2 weeks, maybe a little less for Omicron, 10 days. Next slide, please. The COVID response efforts in Oregon continue to put booster and vaccination efforts out across the state. 1.5 million Oregonians have received their booster dose, including 56% of eligible adults and 73% of those 65 and older. The field ops teams focus on communities and reaching people in the places that are most accessible to them, so that they can specifically reach out to communities in the way and the place and in the context that makes it most accessible to them, including church parking lots and working with local leaders of different backgrounds and so on. The 3 FEMA mobile vaccine units have gone to do vaccination efforts across the state and have been moving around. And the long-term care facilities are hosting booster clinics for residents to try to make sure that those most vulnerable living in those facilities have access to boosters. And over 70% of the residents have received boosters. And I don't know what is shown on the ranked 7th among all states in percent of, because I can't see that part of this slide, sorry. Next slide, please. There was a pretty good surge of people who had been receiving, and those are starting to fall off a little bit now. And I hope that people continue to go, because booster seems to be very protective against Omicron. Next slide, please. We have broken down vaccines and boosters by a grand, broad variety of demographics. This one shows by age how many have received 1, 2, or 3 doses, and our elders, as usual, are leading the pack. Next slide, please. Particularly by race and ethnicity, we are seeing some of the some of the gaps narrow a little bit, but we still have work to do to make sure that there's both access and acceptability of vaccination and our practices to reach those highly impacted communities. Next slide, please. Vaccine for children under 5 is an important milestone for us, and there has been a great deal of pressure on the FDA to approve and make available these vaccines for the younger kids, but the data hadn't yet met a threshold that allowed them to proceed. So they will be meeting tomorrow to review the data again for children under 5. And if it's approved, the start of administration could come as early as next week, depending on the other approvals and authorizations that would be needed. But here are some logistics for you to be considering. The first doses arriving starting next week and extending through into that first week of March. I won't read the rest of this slide, but please be aware that once it is approved, vaccine supply will likely not meet demand until about mid-March, and then supply will likely surpass demand. So setting up our communities for that expectation and to plan for that will be helpful. Next slide, please. For people who have tested positive and are not sure what the guideline is for their behavior and for consideration of contacts, they can call this phone number. This is a new phone number that has been set up through the contact tracing and case investigation teams, if I'm not mistaken, and they will be able to provide guidance documents that are relevant to those cases in 12 languages. So here are a whole bunch of information options that you'll be able to use and share. Please do disseminate. Next slide, please. Therapeutics, as the variants keep coming along and as therapeutics keep being developed and the susceptibility to different variants, to the different therapeutic options becomes clear, providing information about that to our clinicians is one of the efforts that we are working through, including a partnership with OPCA to help some of the FQHCs and make sure that they have what they need. Last week, the therapeutics team started meeting with some of those FQHCs that reach those communities most highly impacted. But if you are trying to work through therapeutics options for your clinical networks and you want to plug into this, please feel free to reach out. We can help work with you on that.
Hi, Dawn. This is Dustin Zimmerman. Yes. So I can just give you some updates on this. So the therapeutics team has met with a couple FQHCs with the support of the Oregon Primary Care Association to try and identify likely 3 FQHCs in a variety of communities, both rural and urban, to see if we can offer support through OHA to kind of help with the amount of work it takes to provide these therapeutics to individuals. So contracting has not begun. There'll be further discussions going on, and we'll keep you updated on where those will land, because we'll likely be looking for some CCO support to help support those FQHCs in your networks. So just to let you know that more information should be coming soon, but nothing has been finalized and FQHCs have not yet been selected. So just thought I'd add that.
Thank you. And I'm seeing a note in the chat that Maggie's saying that vaccines for young kids have been delayed at least 2 months. So as I am working with slides from Kristen and from Melissa Sutton, and I don't actually know the most recent, I'll go ahead and follow up on that for you and make sure that I'm sharing Okay, thanks, Maggie. Sounds like they have decided that the evidence doesn't support young kids yet, but I'm working with hearsay, and I'll make sure that we can get some most up-to-date information for you. Sorry about that.
Hey, Dawn, it's Jeannie.
Jeannie, yes.
There was one other question in the chat that came from Holly Joe, and I'm not sure if you saw it. It was just about and maybe you addressed it and I missed it, but it's just about how the home testing is affecting the positivity rates that you were talking about previously. So we can come back to that at the end if you want. Just want to make sure we don't lose it in the chat.
It's a really good and important question, and it actually calls attention to where the information is most needed. And it's true. It may be that the positivity numbers are higher than we know because we're not aware of the outcomes of the home tests in many cases. That's an important observation. But it also reminds us that we actually are not the ones who need the information the most, even though understanding the data puts us in a better position to build interventions that make sense. I hope that people are using those results wisely, but it's true, Holly Joe, and I would welcome anybody from the COVID team who has a good answer or more thoughtfulness about that to jump in here anytime. But I'm glad that home tests are available to help community members make determinations about what they can and should be doing. Next slide, please. HERC update. It may be that, Dustin, you have some wiser things to say about the COVID update before we move on to HERC.
Nothing to add, just that more information is coming. And also regarding that case hotline, the COVID case hotline, we do hope to have some more texting options. So I'll continue to provide updates both through that Friday CCO operations update letter that you have previously received from David Inbody into this group as well. So we'll just make sure to keep you updated as we get more information, and that's all I have.
Thank you. And it sounds like Kristen Dillon may be able to join us, and we'll have her go back and make sure that she addresses some of those questions if she has some better perspective. And with that, unless there's anyone else who would like to chime in about COVID, any other questions or concerns?
Yeah, this is Bhavesh. I just had a comment that I don't know if there's a potential where people could call in a kind of a general line if they're positive from a home test, just to let us know or let OHA know about, you know, that they have a positive case, and to collect the data accurately. So it could be even anonymous if people are worried about that. But it's simply a way for us to try and capture the rate in the community.
I appreciate that, Bhavesh.
There's a website. My whole family's positive, and you have to go in there and like enter it, but I don't think community people know about this website. So maybe it could be made more widely available.
That's
Thanks,
great.
Safina. We can get that for you here, and also understanding that people are maybe more likely to report if they are positive, but not necessarily if they're negative. It still throws our calculation of rates into question, but it sounds like Kristen Dillon, like you may be on. One of the questions that has been raised, if you are here, is how we're dealing with home testing and the impact that may be having on our test positivity, any of the other rates, case rates, and so on. Are you on, Kristen?
I am. Hi, Dawn. I think basically, you know, we're seeing it as one of the evolutions in this pandemic and how we track things and how we do things. What I'm seeing is really the policy choices around promoting rapid tests and at-home tests and making them more available. the benefit of that really outweighs the fact that our data gets worse, because there are some ways for people to report. Some of them are proctored, but really a lot of that rollout was done with the understanding that especially a lot of the negatives are just not going to be reported. And even in cases, like for instance, in the schools, there's been significant changes in what we're asking the schools to do in terms of what they have to do with negative tests, just because the burden of doing all the reporting was getting in the way of the schools being able to do the testing and do their regular work. And so I think we don't totally know, like, how do you compare a positivity rate from this week or next week to a positivity rate from last October before we had them? We're going to need to figure out what kind of meaning we draw from that. But, you know, basically we've taken the advantage of having very widespread testing and hoping that people will act on those results, giving them, you know, direct public access to support and information should they test positive. And we're just going to have to adjust with the fact that our data is going to have a different meaning than it used to.
Another question that's coming up, Kristen, is about reporting and whether that's something that we are encouraging, and if so, how. A few of those resources have been discussed. This website that's in the chat and also the hotline, but it doesn't sound like that's been widely sort of disseminated in ways that folks on the call have come to understand or be able to use. Can you speak to that?
And honestly, in terms of the exact processes that are going down around trying to continue, I'm not honestly sure exactly which are getting, you know, adjusted or how. Certainly, if folks on this call like aren't aware of the new support hotline and those resources, that's super important information to take back and just continue to amplify the message, and then use, you know, the great forum that this is and that CCOs are, just to keep pushing the message. The last I'd heard, the hotline had gotten over 1,000 calls, and you know, that's in the face of 4,000 cases a day or whatever. So clearly more to do there. So it's good to know.
Thank you. Anything else for Kristen before we move on to HERC? The one last thing that I just remembered is that the slide that we shared said that the FDA was going to be meeting tomorrow about immunizations for kids under 5. I went ahead and shared that, and then was corrected in the chat by my colleagues who have been more attuned than have I. If you could speak to that very briefly.
Yeah, sorry about that. My last week brain and my this week brain are like really loosely connected with each other right now, it appears. So thanks for your understanding. Yeah, all of us, healthcare entities, a whole bunch of us, parents, did a 2-week scramble anticipating potential authorization for under 5 next week and potentially starting shots as soon as Monday the 21st. With the understanding the messaging was going to be pretty funky, because it was going to be something like, well, we know the shots are safe and we think 2 is kind of helpful, but you'll probably need a 3rd, maybe, depending on your age, but we don't know yet. So there again, you know, it's all about cost benefit, right? And so the benefit was, in the face of an Omicron surge that's affecting a huge number of kids, we could start to get them some coverage. And the downside was, for people who have concern about the speed at which these were developed, feeling like it's experimental or unsure, that whole process was just going to play right into that. So I honestly did have my own sort of personal wonderings about, I wonder ultimately if we're going to reach more or fewer children and do more or less benefit by starting it now. And then higher ups smarter than us decided, you know what, Pfizer got some more data. It really showed that 2 to 4 year olds were not as well protected as we would want with the 2 doses. So we need to be sure the 3 doses is going to work at that 3 microgram dose. So basically it's a 2-month delay. It looks like that data will be done in late March, and probably FDA will meet in approximately April. And so I'm anticipating, you know, sometime between April 15th and the end of the month will be a rollout of the product and the begin of vaccinations. It'll be about 2 months, I expect, of kind of a good surge. Hopefully we can, and the data, the parent survey data is looking pretty good, actually. About 1/3 of parents are really eager to get their kids vaccinated, which is about what we saw in the 5 to 11-year-olds. And honestly, I'm pleased if the younger kids and parents of families of younger kids are going to be able to do that, because we were anticipating the uptake might be even lower. All right, I was seeing, and so it's you know, it means we're restarting all our planning to have a little more measured rollout than we were going to have when we had to do it next week.
Thank you, Kristen.
So I see Safina Qureshi's question. Initially they were testing the 5-year-old dose, the 10 microgram in kids 2 to 4. And what I saw in a press report is that it caused fever in 1 out of 5 children who got it. So the decision was made by the manufacturer, FDA, I don't know if they consulted with FDA, but the decision was made that a 3 microgram dose, which is what was originally tested in 6 months through 1, would be a better way to go. We're now seeing the downsides of that decision, which is it may take 3 doses instead of 2. And I think we're not even positive yet how well 3 doses will work, but we will know soon before we start giving it to kids.
Thank you. Anything else? I will ask Kristen to run back through these slides real quick to make sure that there aren't any others that needed to be updated.
Thank you.
That I wasn't attuned to.
No, you're good. I'm just looking at, you know, the case data is all good. You know, vaccines, while they may not be as strong as we had hoped, particularly against infection, and just terrific protection against hospitalization and death. And we are continuing though to see, you know, I think you all probably saw the media reports, the boosters in adults maybe also have somewhat of a waning effect after 4 months or so. So just continuing to learn as we go and trying to do the best. Booster doses looking good. And I guess on the race ethnicity data, particularly around boosters, but also kids, we do continue to see gaps across race ethnicity. The largest inequity is impacting the Hispanic, Latino, Latinx community. Other racial ethnic groups seem to really be closing in terms of the gap compared to the average of the general population. The Hispanic, Latino, Latinx gap is also closing. The percentage of eligible folks who identify that way, who've received a booster, is gradually, you know, becoming a higher and higher percentage of what we see across the general population. We're working really closely with community representatives, you know, people who have that identity, to try to understand, is it an access thing? Is it about misinformation? Is it about, you know, documentation? What are the factors that we can help to mitigate to get those rates up? And I think that's just something for you all to continue in your work. And also as we get ready for the rollout with kids, is really, in order to meet our equity goals, really adding resource, adding focus, really connecting with people who identify as Hispanic, Latino, to understand how can we reach them with vaccines in ways that work for them, is going to be really important in the coming months.
Thank you, Kristen.
Thank you. Thanks for pinch hitting for the pinch hitter. Good job.
I'm sorry. I'm sorry for any lapses in quality that may have resulted from my pinch hitting for the pinch hitter, and feel free to ping in the chat for anything else that didn't make sense. And Kristen is reviewing there also for content that she can respond to here. And with that, I would like to see if Ariel is on. Ariel Smith, medical director for the HERC.
She's there, Dawn, but she's muted.
You hear me?
There, now we can hear you.
Okay, sorry. My computer just likes to randomly shut my speaker off.
Good morning.
All right. Okay, so I'm here for the HERC update. Next slide. We don't have a lot of new stuff to report. Our January VBBS and HERC meetings and our February EGBS meetings were canceled. So nothing new to report that are decision-wise. Next slide, please. There are a couple of new COVID codes. These are the small kiddo vaccines that you heard were supposed to come out and maybe not come out. And I guess they're not coming out now. So anyway, we are adding them to line 3. We have a guideline that just says that once the FDA and the CDC approve these, then they are active. So if and when they're active, that gets done, then you can use these codes. Next slide, please. So our March agenda is pretty full. We have some stuff carried over from November. Platelet-rich plasma, which I know that you've all had a lot of interest in. We are not suggesting adding any new coverage. Radio frequency ablation for renal tumors, we're going to suggest adding some coverage for that. Pelvic vein congestion is just really a clarification that we don't cover that diagnosis. Breast MRI guidelines is actually a pretty substantial reworking of all of our breast screening guidelines. So you'll want to keep an eye out for that. And then we are trying to clarify whether our guidelines saying that we cover reconstruction after mastectomy also includes lumpectomy, which is coded as partial mastectomy. So those were actually all on the November agenda. You've been hearing about them month after month. Hopefully we will actually get to them in March. Next slide, please. And then other items on the March agenda, newborn home visits. This is actually a legislation that passed. We're just doing some coding to assist in being able to provide that. Some coding changes around ligament and tendon injuries. PICA in adults. We currently have a line that's just PICA. The code for PICA in children is not on that line. It's on a covered line. We've had a lot of concern from pediatric advocates. So we're basically going to rename the line PICA in adults so that a lot of that concern hopefully will go away. Foot arthrosis will be reviewed again. There's a recommendation for no change. Also, gastric neurostimulators. This was a question from one of the medical directors. This gastric neurostimulators actually are not FDA approved. They have humanitarian exemptions. So our understanding is Medicaid can't cover them. So we're not actually going to review the evidence for that. Then there's some congenital foot deformity review, gait analysis and surface electromyography. That came from one of you guys. Clarifying coverage or whether we do cover that or not. And then updating our chemodenervation guideline, which is technically our Botox guideline. There are a couple lines that are not in that guideline, and mainly because they were pretty straightforward what we covered on those lines, but we're going to add them just for the sake of completeness and to answer some questions that have come from you all. Next slide. We are starting our 2024 biennial review. We're looking at dorsal rhizotomy for spastic diplegic cerebral palsy, which we currently is, it's below the line. Proposal is to move it above the line. We also have a line for agenesis of lung, which we couldn't find any claims for going back several years. And we're thinking of just removing that line completely and putting that into the line for pulmonary items that don't have any treatment. Autoimmune encephalitis placement, this is probably not going to come for March. This has a lot to do with our Panda Pans work. So keep posted on that one. Actinic keratosis. This is a precancerous skin change. We currently don't cover it because the rate of conversion to skin cancer is very, very low. And when it does convert to skin cancer, it's basal or squamous cell and is easily treated. We were queried about our lack of coverage, and so we are going to go through it again. We're mainly looking to see if there was a change in any of the data on rates of conversion, and it's still extremely low. So likely we're going to continue to not cover. Enteric arthropathies, these are things like Crohn's disease that end up having more systemic effects on joints, et cetera. We're going to move these to a covered area. There was some questions that came up about chronic kidney disease, just basically the ICD-10 codes for what should be covered for erythropoietin. And a lot of it's ICD-10. Unfortunately, I'm sure you're all aware, ICD-10 is very difficult for a lot of providers. And so we're going to move some codes just to hopefully ease the ability of providers who are caring for chronic kidney patients. We're going to clarify our lower urinary tract symptom guideline, just some basic clarifications there. We're going to look at sensory integration therapy, everybody's favorite. Next slide, please. And then we have tons of things coming. It seems like we were kind of in a lull during COVID, but now we're not in a lull. So we're looking at our solid organ transplant lines, mainly putting in some type of guideline or working with HSD about their rules. We're looking at a lot of the below the line conditions. We're doing sort of a comprehensive review. So some more things may come out of that. The autoimmune encephalitis that I talked about earlier that's coming with the Panda Pans decision. We've been asked about bilateral BAHA, the orthodontia stuff that we're still working on very closely with HSD that I'm sure you're all aware of, that we are going to try to cover orthodontia for handicapping malocclusion, and we're just continuing to work on making sure our guidelines follow what HSD decides will be the rules. We've been asked to look at coronary CTA, autologous chondrocyte implantation, and then there's about 6 more items that have come across my mailbox since I made these slides. So lots of things are coming fast and furious at us. So you have lots of stuff to look forward to or not for future meetings. Next slide, please. Our next EGBS meeting will be in April. We're continuing to work on Panda Pans. Pandas is pediatric autoimmune neurologic disease after strep infection. There was a very robust public input on our proposal. So just to remind you all, the proposal that went out for public comment basically said that we won't really address things that we don't have a lot of levers for coverage. So things like single antibiotic courses, single steroid courses, psychotherapy, SSRIs, those types of things. We took out of the coverage guidance and basically said that we would cover IVIG and plasmapheresis if it was recommended by 2 pediatric subspecialists after a child has tried and failed 2 less intensive therapies, and then reassess the need for IVIG and plasmapheresis at every 3 months. We have gotten, like I said, a very substantial public comment. Some of the changes that we're going to discuss in April would possibly be, instead of 2 pediatric subspecialists, we would have 1 pediatric subspecialist and the primary care provider, both seeing and agreeing that the patient could benefit from IVIG or plasmapheresis. And in the case of adolescents, they could see an adult subspecialist possibly. And that we're specifying that the subspecialist visit could be a virtual visit just so that we can allow better access. We are clarifying that you have to try and fail these less invasive therapies that could be done concurrently. And what we mean by failure is that a normal trial. So it could be a 1-week antibiotic course, it could be a 6-week SSRI course, et cetera. And also that there could be just prolonged improvement, and that's because improvement with steroids and then subsequent relapse actually can predict that IVIG might work better. So we've made all of those suggestions. And then how we're deciding if you try or fail is a standardized, verified, validated instrument geared toward whatever is the child's most presenting symptom complex. So if it's OCD symptoms, then some type of OCD scale. If it's depression, some type of depression scale, etc. And then we're going to continue recommending non-coverage of surgical interventions like tonsillectomy or adenoidectomy and long-term antibiotics because there's more harm than benefit. So this is all coming on April 7th. And we are, this may pass and then come out to HERC after this meeting. It may go out for public comment again. So definitely still working on this. And then we have a next slide, please. So this is just the blue box language, this is just the proposed language that we are bringing to the April meeting. This is not in any way final language, but I wanted to put that there for your reference. Next slide. And then future topics, we've had a couple things proposed. One is we previously had done a bariatric surgery review. There's been a request by a bariatric surgeon and a CCO to kind of look at that again for updates and procedures and types of centers, et cetera. We've also been asked to do maybe a more in-depth look at continuous glucose monitors. So those are two possible topics. Beyond that, we're definitely looking for topics for EGBS. So if there's anything that you think could benefit from an in-depth review, please let us know. We would definitely be interested in hearing about that. And also anything that you have questions or want HERC to look at, obviously, please continue to bring those. And like I said, they've suddenly come fast and furious. So I think as COVID is starting to wane, all of these other questions are coming to the forefront. So next slide, please. And like I said, we're always interested in questions, issues, etc. The best way to reach us is at herc.info. That makes sure that it comes to the right person, but you can always send things to me or to Jason as well. Any questions? Anything I can answer today? Anything that you want me to bring back to the HERC? Any other discussion?
Ariel, this is Manish. Just some comment on, I know there's been some back and forth between our medical director with you about the changes in pediatric coverage for children for things that would otherwise be below the line in terms of the comment around child well-being, growth, development, and other needs that might trump it being below the line.
Yeah, that's a very complex topic. So what Bhavesh is referring to is that we changed one of our ancillary guidelines at our November meeting to say that items that affect a child's growth, development, or ability to participate in school need individual assessment to see if they're medically necessary for coverage. This goes along with, I don't know if you all saw last week, I think, it might be the week before, there was a news alert out from OHA that we are no longer seeking deferment from EPSDT. So in our next waiver, we anticipate that being approved by July, there will no longer be a waiver of EPSDT. EPSDT is early prevention, screening, and treatment for children. What this means is that for a child, you can't just say something is below the line and therefore not covered. You have to take an individual review and see if in that child's specific circumstances, is that treatment medically necessary? Dawn, you might want to, I don't know if I quite said that correctly, so jump in if you think there should be any more nuance there.
There is a good deal of work going on at HSD to flesh out more guidance around it, because some processes need to change to adapt to that. The medically necessary and appropriate nature of a particular request depends on that child's condition and the relationship of that request to the rest of the needs of the child. And we need in particular to be sure that that we are not being discriminatory against those with special needs. For example, using the guideline and the prioritized list. So that individualized case review is how we as medical directors across the CCOs, as well as in the fee-for-service program, have the opportunity to better understand the medical necessity and appropriateness for any given request. That's what the case review requirement is about. It's also the requirement of the EPSDT. So we'll keep working toward getting you some more specific guidance around that. And I appreciate all of your collaboration and open communication with me as you start to review these cases and learn more about what those guidelines might look like to be most effectively implemented. Thanks for the question. It's a whole lot of work is happening on it right now.
That's great. Thanks, Dawn. And I also wanted to add, perhaps from a funding perspective, to also measure the expansion of coverage that may happen as a result, could result in a shortfall in coverage available in terms of the funding needs. And so just making sure that as we measure how this affects the movement of approvals to make things that would otherwise have been below the line become medically necessary, how that might affect the available funds that are being predicted. So just wanted to also throw that into the conversation, please.
Yeah, and a lot of the stuff is hopefully already happening where you've already been doing some individualized, exceptions process, but yeah.
And we are, as part of the work that's happening at HSD, those financial considerations are also being evaluated. Babish, thank you for the reminder about it. Other questions? Let's go ahead and wrap up now. Thank you, Ariel. And let's take a break and go ahead and return in 5 minutes at 11 o'clock for the Traditional Health Workers Learning Collaborative. We'll see you back at 11, 5 minutes, please. Thank you. Thank you. A health equity consultant who has worked with OHA to support equity work by CCOs and Oregon's patient-centered primary care home. Last year, he facilitated CCO learning collaboratives about the integration and payment for THWs, traditional health workers, and about the meaningful language access incentive measure. He also has served on health equity advisory groups for national organizations, including the National Quality Forum, National Committee for Quality Assurance, Joint Commission, Institute for Healthcare Improvement, Patient-Centered Outcomes Research Institute, American Board of Internal Medicine Foundation, and Families USA. Please welcome Ignatius Bau. Thank you for joining us.
Thank you, Dr. Bentler. And I'm not going to be speaking, I'm just going to be facilitating the conversation. So welcome back, everybody. It's a real pleasure to bring together the presenters, the speakers that will be presenting today, to talk a little bit about traditional health workers and how they can support improved quality and health outcomes for Oregonians, particularly through the Oregon Health Plan and through the coordinated care organizations. So as you've seen from the agenda, what we're going to do is start with a little bit of an evidence review to talk about the evidence for supporting traditional health workers, different types of traditional health workers, community health workers, doulas, peer specialists, patient navigators. They come with different names and different types of job responsibilities and strengths. And we want to highlight the variety of traditional health workers that are out there. And then we're going to turn to Mohammed from the Division of Equity and Inclusion to talk a little bit about OHA's approach to supporting traditional health workers, which has been many decades in the making. This is not a new enterprise. And then most importantly, we're going to hear from coordinated care organizations themselves and how they are integrating traditional health workers and traditional health worker programs and services into supporting quality and health outcomes. And then we'll have a little bit of time at the end for some conversation with all of you and questions throughout after each of the panels of speakers. So I'm going to launch right away with the evidence review. We have two speakers. First up is Dr. Valerie King, who is the Director of Research at the OHSU Center for Evidence-Based Policy. She completed this evidence review with her team a couple years ago, and she's going to provide an overview of that. And then she's going to be followed by OHA staff member Summer Boslaw, who is a transformation analyst at the Transformation Center. One of her responsibilities is supporting the Primary Care Payment Reform Collaborative, as well as working with the Value-Based Compact working group as well. And so Summer's going to provide an overview of some research that she was able to pull together about traditional health workers and quality and value as well. So let me first turn to Dr. King.
Hello there. How is my sound?
You're great.
Okay, fantastic. I am not seeing any heads up. Are you projecting those?
So yes, we are working on getting the slides up.
Oh, okay, fantastic.
So why don't you just go ahead and while we do that.
Okay, great. So just before we truly get started here with the slides, thank you so much for that kind introduction. Work for the HERC and its coverage guidances, and we do the evidence backgrounds. This particular review was for a multi-systems intervention, so that's a broader look that includes not just what HERC recommends payment for in the Medicaid program, but also things that are across sectors that public health and other aspects of the OHA might be involved in. This review was done in 2019, so a little bit ago. It really dates from them. It's changing all the time, so it's just a little brief background. Let me
So, Dr. King, you are cutting out.
Hello?
You are cutting out a little bit, so maybe you can get a little bit closer to the microphone.
Hello, are we back now?
Yes, that's much better.
Okay.
Thank you.
Good, sorry, I don't know what happened there. So I'm not yet seeing slides, so I'll just start going through what I think is in the slide set, and I think most of you probably have this as an attachment and can follow along. So in this particular evidence review, as you know, we really found that community health workers were referred to by a multiplicity of terms, and that was everything from community health advisors to ambassadors to community liaisons, patient navigators, health advocates, peer advisors, outreach workers, promotoras, et cetera. So lots of different terms, and we basically, in the evidence review, took anything that was even close. The HERC develops a scope statement every time we do evidence work for them, and that is guided by a PICO statement, so population, intervention, comparator, and outcome. In this case, the populations that we were looking at were adults or children, really with chronic diseases. The interventions were engagements, and I'm on slide 3. Thanks. Awesome. The interventions were any kind of engagement or outreach by a community health worker. The comparator was just what would happen normally, and that could include other ways of activating or engaging patients. Next slide, please. And the HERC selects both critical and important outcomes in its work, and selects 5 of them. So in this case, the critical outcomes were morbidity measures for those chronic diseases, emergency department visits and hospitalizations, and then the important outcomes were adherence to medication or other care regimen, and then finally a look at whether there were any broad harms that were reported from these engagements. Next slide, please. Based on that set of PICOs, we developed 3 key questions. One had to do with the effectiveness of community health workers for those health outcomes, and also whether they were effective for reducing healthcare utilization. We looked at subgroups, if they were available, about whether the effectiveness of community health workers would vary by anything to do with the patient or the patient's condition, whether there were any things about the community health worker themselves or the intervention that was being applied by the community health worker that might change the effectiveness or the harms. And then finally, the 3rd key question was around harms. Next slide, please. So just a really brief summary of the evidence. There were many studies. They were a bit mixed in places. And so what we're talking about here is really the preponderance of the evidence. Because the outcomes were, and the interventions themselves were so heterogeneous, it was almost impossible for any of these systematic reviews to have come up with a combination in a meta-analysis. And so this is a pretty qualitative synthesis. So although there were some mixed results, we really felt that in high-income countries akin to the US, that community health workers did have evidence of improving chronic disease-specific health outcomes. They reduced emergency department visits and hospitalizations on the whole, and at commonly established willingness to pay thresholds were cost-effective or cost savings, actually. There was a bit more evidence for community health workers in relationship to children with asthma and adults with either diabetes or hypertension. And there was relatively less evidence about people who were living with HIV or serious mental illnesses. So let's go ahead to the next slide after that broad overview. Are you all seeing the slide? There we go. Okay, there was a bit of a delay, but I'm never sure if it's me or another place. So in some of these studies, we did find, this gets to some of the subgroup analysis, we did find that with higher intensity interventions, so more contacts, more frequent contacts, that you saw a greater improvement in outcomes. And not surprisingly, improvement was easier to demonstrate in populations that had more severe disease and disease characteristics at the baseline period. So they just had more room to change in a positive direction. There were some studies that indicated that if the intervention was targeting people who had a prior preventable utilization, so something, for example, that was judged to be a prior preventable ED admission, that longer interventions and interventions that incorporated community health workers as part of a whole integrated care team were then associated with greater reductions in healthcare utilization. So both for people who might have had questionable healthcare utilization, at least from our perspective, in the healthcare system, those longer and more intense interventions and more integrated interventions seem to work a bit better. So next slide, please. So as I said before, there's a lot of heterogeneity across this literature base. The populations, what kind of community health worker was being used, what kinds of interventions those community health workers were actually engaged in, how intense or long lasting that intervention was. And, then there were differences in the theoretical basis of the intervention. So the theories of change and social engagement that might have been used. In some of the studies that were included in this review, community health worker interventions were combined up with other interventions. So they might have been integrated with intensive case management. In the case of serious mental illness, they were often integrated with ACT or assertive community treatment. And because of that, it makes it a little bit difficult to establish the independent contribution of community health workers, but certainly as part of a team or integrated effort in these studies, you did see the observed effects. There were authors of systematic reviews we included in our evidence review that did raise concerns about the possibility of publication bias, basically meaning that if there were negative results of a study of community health workers, they were concerned that maybe those were still sitting in somebody's file drawer and just hadn't been published. So there might be negative literature that just is out there that we're not seeing. And then most authors of these systematic reviews did regard community health worker interventions as promising. And thought that they were particularly good about improving outcomes among people who were in pretty vulnerable or at-risk situations in the community. So let's go ahead to the next slide. Just a little bit here on policies and guidelines, and again, this is dates from 2019. NASHP established an online database of community health worker models across all states, finding that about a quarter of the states at that point had certification programs, and that one of those states, Oregon, where we are, was requiring that community health workers be certified in order for those services to be covered by Medicaid. That situation may have changed substantially in the interim. On reimbursement, that about half of the states at that point were paying for community health workers with Medicaid funds, generally through managed care contracts, that some states were using other funding sources for community health worker interventions, so for example, FQHCs or other community-based organizations. Let's go ahead to the next slide. There were guidelines that generally came out of the Community Preventive Services Task Force. This is the population or public health initiative that's really similar to the U.S. Preventive Services Task Force for individual preventive services. And in between 2015 and 17, the Community Preventive Services Task Force put out recommendations that mention community health workers around cardiovascular disease prevention, diabetes management, and diabetes prevention, finding that at least half the time there was strong evidence for those interventions, and then sufficient or okay evidence for the others. Let's go ahead to the next slide. Also, there is a 2018 WHO World Health Organization guideline that really crosses all kinds of world situations. And their review, the evidence review that backed up the guideline, really found some evidence that community health workers were effective for chronic disease situations, including behavior change around those diseases, communicable diseases, maternal and newborn health situations, extending on into child health, and then both mental health and sexual and reproductive health all had evidence of some degree of effectiveness. Let's go ahead and go to the next slide. And then that's really the brief tour through that report. It's available in your attachments, I know, and I know that Ignatius, you've asked for questions to be put in the comments, and happy to deal with any of those now or wait until the end of this particular section. Just let me know what you'd like to do.
Great. Thank you, Dr. King, and thanks for that overview. I particularly appreciate your, referencing what other states and even globally what we know and have learned about community health workers and traditional health workers. And that's always an important reminder. I am going to hold questions, but I encourage folks to chat, use the chat function to type in questions. But let's go ahead and turn to Summer for her overview, and then we can take a little bit of time for some conversation about the evidence. So Summer?
Great, can you hear me?
Yes, go ahead.
Okay, well, wonderful. Okay, this research was done, prompted by the Primary Care Payment Reform Collaborative, which is a multi-stakeholder group that has been meeting for a number of years now, developing, focused on increasing the primary care spend and changing the way payment is done to improve quality and reduce cost. And they spent some time last year thinking about how could primary care payment reform increase health equity and reduce health disparities. And one of the key areas that they wanted to focus on is the incorporation and integration of traditional health workers and sustainable support of that integration. And to start that, they wanted to look at the research around quality impact and cost impact of integrating traditional health workers, and then look at payment models. And I know that Mohammed, who is speaking after me, I think will dive deeper into the payment models. We did look into one that kept coming up as a successful model in New Mexico, and I'll speak to that in just a minute. So next slide, please. And I'm just going to look at, I won't look at the research that we found on community health workers because Dr. King just went through that. So I'm going to focus on the other traditional health worker provider types. So first, looking at doulas, and I found a number of different studies. One, a retrospective program evaluation of a hospital-based doula program in an urban multicultural setting through the first 7 years of the program, found that women with doula support had significantly higher rates of breastfeeding initiation and lower rates of cesarean section. A YWCA community-based program called Healthy Beginnings doula program launched in Greensboro, North Carolina, focuses on reducing adverse birth outcomes for women at risk because of racial disparity. They're particularly focused on African American and Hispanic women, those that are experiencing homelessness, interpersonal violence, unhealthy housing, poverty, or young age young age mothers. And the study of the program found doula-assisted mothers were 4 times less likely to have a low birth weight baby and 2 times less likely to experience a birth complication involving themselves or their baby, and significantly more likely to initiate breastfeeding. Next slide, please. A randomized control trial of a hospital-based continuous support in labor to low-income women program by a doula at a women's ambulatory care center in New Jersey, found that doula-supported mothers had significantly shorter lengths of labor and more cervical dilation and a higher infant APGAR score at 1 and 5 minutes post-birth. And then a nationwide study of community-based programs where women received doula care during labor and delivery in comparison with a group of women who only received doula care about childbirth-related education, but not during labor and delivery. Those that had doula care during labor and delivery had a 22% lower preterm and an average savings of $986 per birth. Next slide, please. And then looking at personal health navigators, patient navigators, a study of the Cancer Disparity Research Partnership, which is a community-based program in South Dakota for Native Americans, found that patients with health navigators undergoing radiotherapy had fewer treatment breaks compared with patients without health navigators. And the success of the program resulted in fewer referrals out for treatment, and thereby significantly increasing healthcare dollars available for the cancer treatment. Next slide, please. And then quite a bit of evidence related to peer support specialists, and this is findings from 5 different studies. In a Georgia Department of Behavioral Health and Developmental Disabilities program compared a clinical-based program where consumers using verified peer specialists as part of their treatment versus consumers who just received the normal services in day treatment. The study found that consumers using peer support specialists cost the state almost $1,000 per year on average versus an average cost of the day treatment without the peer support specialist of almost $6,500, so providing an average cost savings of close to $5,500 per person per year. And then New York Association of Psychiatric Rehabilitation Services launched a clinical-based program that matches peers who are managing their recovery and who have completed training, specific training to be peer support specialists, and they're matched with patients who are just beginning treatment. And an evaluation of that program found that 71% of the patients that were just beginning treatment were able to stay out of the hospital, and 54% had not been rehospitalized. A community-based program in Pierce County reduced involuntary hospitalizations by 32%, leading to a savings of $1.99 million in 1 year. And then a clinic-based federally qualified health center in Denver implemented a peer support program that saved $2.28 for every $1 that was spent on the program. Hey, Summer, this is Jeannie.
Yeah.
Really quickly, can you just clarify when you say individuals matched with certified peer specialists, certified peer specialist means OHA certified peer specialist?
No, very good question. No, none of these programs were implemented in Oregon, so I don't know what the certification means in the state that it was implemented. That's a good question, something that would look into. So this one, the one that was certified peer specialist in Georgia, I don't know what the difference is between their certification of peer support specialists and those in Oregon by OHA.
Yeah, okay, thank you.
Mm-hmm. And then looking at family support specialists, I couldn't find any evidence of quality or cost implications
There was early research showing that that parent peer support offers parents and other caregivers a number of different helpful assistance in really impacting their ability. Oh, I'm sorry, next slide. Really their ability to provide care to children. That there was when parents had family support specialists or parents or caregivers, there was an increased sense of collaboration. They felt like there was decreased internalized blame, increased sense of self-efficacy and their ability to be a good caregiver to the child. Recognition of the importance of self-care, so recognizing that they needed to support themselves as a key factor in their ability to provide care for the child. Decreased family isolation, an increased sense of empowerment to take action, and increased acceptance and appreciation of the child's challenges, which then increase their ability to work with both formal and informal supports. So there was a variety of different studies that I found of programs throughout the country. So now I'm going to shift into talking a little bit about a payment model in New Mexico. Next slide, please. So what the Primary Care Payment Reform Collaborative was really looking for in this document that OHA created for them was wanting to identify what are a few value-based payment models that will support the integration of traditional health workers into primary care. Unfortunately, there are not, there really weren't any true value-based payment models that I was able to find out there to support traditional health workers. What was cited the most in a variety of different studies and research was a model in New Mexico to implement and support community health workers for patients with complex health and social needs. And this is with a managed care organization, and it's a per member per month payment. And they started out with a pilot of 3 clinics and was focused on patients with complex health and social needs. And there was the cost increased over time, and it supported the CHWs to provide a wide range of services, including helping them have better access and navigate the healthcare and social service system, managing their chronic disease, and obtaining necessary resources that are not typical to healthcare, such as refrigerators. Next slide, please. So the impact of this pilot program proved very valuable. There was $4 saved for every $1 invested, fewer emergency department visits, fewer inpatient admissions, fewer prescriptions, improved diabetes, HbA1c, and lower cholesterol levels, and increased cancer screenings for breast and cervical cancer. And with these results, the MCO program expanded to sites in 33 counties in New Mexico, and aspects of the model have been replicated in 10 other states that are served by the same MCO. Next slide, please. So then they expanded the model for patients with low risk and had good results as well. And so this is patients with lower clinical risk who have higher social needs that have been identified. They found that there was improved adherence to treatment plans, increased attendance at appointments, reduction in no-shows, increase in breast and cervical cancer screenings, colorectal cancer screenings, and an increase in pap smears. Next slide. So they expanded the program. In 2014, New Mexico mandated that all Medicaid MCOs directly hire or contract with CHWs. And they've increased their number by a set percentage beginning in 2016, year over year. And in 2019, the state mandated that Medicaid plans provide CHW services to at least 3% of their members, which would be nearly 20,000 people. And so now there are CHWs that are working in FQHCs, hospital EDs, clinics that serve the uninsured. They're also working in social service agencies, legal assistance agencies, and workforce and reentry center for recently released jail detainees. So they've really taken the model, expanded it in clinical settings, and taken it out to community-based and social service settings. Next slide, please. And so it has been implemented by the same MCO who works in 10 other states, and was assessed and is being considered to implement in Connecticut as well with another payer. And the modeling that was done to inform the decision for Connecticut showed that it would result in an 81% reduction in ED visits and a ROI of $2.40 for every dollar invested. I think that's my last slide. Yeah, so I'll stop there and I guess save questions to the end. Thank you.
Great, thank you, Summer. So I particularly appreciated your highlighting through some of those studies that these are directly about either the Medicaid population or about traditionally underserved communities, including African Americans, Hispanics, Native Americans were among some of the specific examples that you highlighted, where the research showed not only the improved quality and health outcomes, but that return on investment, so directly relevant to the CCO experience here, and also obviously really leveraging the lived experience and the shared life experience of peers with the CCO members or Medicaid managed care members that they are assisting. And so that concept of workforce that is more reflective of the community being served is also really important. So there are a couple of questions. So first, Dr. Savage, do you want to ask your question?
I mean, the first one's just more of a statement. It seems like here what we're struggling with is I feel like a lot of people are very positive about peers and CHWs and want to get those programs going and fund them. What it comes down to is that when you then go to fund that and have a sustainable program, you end up saying, well, I can fund this peer, but I can't fund this peer, and I can fund this one and I can't because one is billable with OHA and one's not. And in order for it to be successful, and then what the CCO does is ends up basically funding something if they can, and then figuring out a way to apply that to a medical expense, right? You have to figure out how to get that all in the right bucket. And I think if there's some way to work through that barrier and say a peer service is defined as a peer service, and however you want to certify it, it sounds to me like peers in other states are just as effective regardless of having OHA certification or not. And looking at what that basic certification is, that getting past that barrier of allowing peer services to quality peer services to be paid for would make this a much more sustainable process, have sustainable funding. Does that make, am I making sense? I know there's not much of a question there, but.
So I think the point that you're raising is that there does need to be, I think we all agree, some level of qualification, training, certification or qualification process. And our next speaker is going to talk about what we have in place in Oregon, and we can certainly raise, whether there need to be changes in that process. There's also a question from Jeffrey McWilliams about sort of what the staffing ratio or service ratio is, if you will, of how many people can be served by a community health worker. And my response would be that that really depends on the type of program and the type of model. And we'll hear some specific examples from our CCO panel in a moment. And then finally, Kat Livingston says it would be great to share the examples. And yes, all the footnotes in Summer's great piece go directly with all the references of where those outcomes come from. So let me turn to Abdiasis Mohammed from the OHA Division of Equity and Inclusion, who is the OHA THW Program Manager, to give us a little overview of that certification payment process that is in place. And obviously a journey, as he says in his title, that we're still on. And so Mohammed, take it away.
Thanks, Ignatius, and thanks everyone else here. My name is Abdiasis Mohammed. I am the program manager for the Traditional Health Worker program within the Equity Inclusion Division at OHA. I will be basically talking a little bit, I think, with the condense of time. I didn't know how much we should share and how much, and there's a whole lot of colleagues within our CCO who we in conjunction work with them that will share an in-depth of how it is done on the ground from a managed care organization perspective, and many of the literatures I think that was shared earlier. My focus is within the policy level arena. What are we doing within OHA in terms of moving this work forward? And kind of going back to the previous question, which I may go to the next slide, please, if you could go ahead, was about what are some of the, specific certifications and things like that Oregon has. And I think if I may answer that question, Oregon has been ranked as like one of the 4th national states that ranks has like a model of state certification in place. And you will see this a lot, I think, along various trends of the THW workforce that we are talking about today, which is, family peers, youth peers, or maybe what do you call, community health workers, doulas. We are basically, I think, ranked in each specific workforce. If you talk about peers, for example, I think the National State and Health Policy and other groups have ranked Oregon as one of the 4 best practices in the state that has some kind of a model and a certification and an organized and a system in place that for peers within the various states around the nation. That was one thing that I think it was a big achievement for Oregon, being ranked in that bucket of a model and a structure that is in place in terms of from certification to delivery of services to basically talking about payments and billing. And in essence, also there were like the issues around, you talked about, how many peers are we talking and are they certified versus not? When mostly, I think average 85% are people who are certified with the state that do provide behavioral health, addiction, mental health services to the various, Oregonians in various pockets of the state. And so that is how we are better kind of structured. And so, and then similar models are happening for maternal child health, like doulas, where a lot of states are looking Oregon as a model. There we get calls from various governors' officers asking about, how Oregon is doing. And so I think there's a lot of work happening in here, but we are not out of the woods yet to address some of the shortcomings regarding, for example, better integration or, for example, payment reforms. We are not there yet. Although when you look in comparison to other states, they are just starting a program now of like setting up a certification or things like that. We are basically talking about how do we pay for better delivery of services and how do we impact health outcomes for Oregonians, which is, I think, way ahead on the curve when you look for other states a little bit. But for the purpose of this presentation here, I'm gonna quickly rush through to talk about some kind of comparisons, like, when we set up CCO 1.0 versus where we are today and what are we looking forward to 3.0 down the road that will be helpful for the committee and everyone alike here to really kind of get a grasp of, where are we with this workforce in the state. If you can go to the next slide, please. So the first one I'm gonna quickly talk about is, what triggered some of the reforms you all may hear about traditional healthcare workforce around the state. You all know, in 1.0 world, there were already, some discussions on talking about how can we do better with the integration, with the healthcare transformation that the state took on, about 7 years or 8 years ago. There was that discussion of bringing this workforce to really help embed preventative health and other elements regarding, better improvements for health, providing culturally and linguistically appropriate services. And all that was the goal, to improve, and maybe the workforce that, traditional health workers are called in Oregon can really deliver a better job in terms of being part of that, the delivery of healthcare services to Oregonians alongside providers and other elements that we have. But one thing we looked back in 2016, 17, before we even start talking 2.0, was a reflection of, the last 5 years of the beginning of 1.0. What were some changes we were seeing a little bit in terms of, improvement and things when we talk about traditional healthcare workforce. And this list here are some of the things, that we were able to see in terms of 1.0. For example, some minimal accountability were there. For example, there were no better system and infrastructure that would really, hold managed care organization in relation to, a more broader, elements of what, what we want to achieve in terms of health inequities. And then in addition to, there were not so major, improvements towards probably, service delivery. There were like few contracts here and there. For example, there were no structure and organized system of talking about, how do you really embed traditional health worker in primary care, in community-based and other settings as well. There were no more structural there. It was more this broader contract language that we had that kind of said, well, we want you to bring this workforce and work with them and embed it. And so there wasn't a lot of, movement around there as well. And there was also a bit less investments in terms of THW workforce that, we kind of also seen. For example, some of the managed care organizations had a lot of great robust programs, and others had, different way of investments. For example, providing trainings, like putting money towards that, but not so much about employment and sustainability and keeping the workforce there. And so there's also, over time, we have also seen, some shift in terms of, social determinants of health investments, but they were not so much out there. And, there was so much little known about employment and utilizations of THWs, for example, to address social determinants of health. There wasn't so much broader aspect of that in 1.0. So then there's a big segue of, in 2018, the commission and other folks within that really support the work of this workforce kind of got together and say, what can we change a little bit to take advantage of, 2.0 to really bring in our managed care organization alongside this workforce so we can really, make a dent in terms of the health inequities and how this workforce can be part of Oregon's vital workforce. If you can go to the next slide, please. Then, there were these intended impacts that the goal was, through the Oregon Health Policy Board and other, suggestive, processes, creating policies, and that later became, what informs the 2.0 contracts today. There were these three key main elements that was, regarded highly to really make a change. One, increase the workforce by also creating a livable and equitable payment system that can really sustain and support the workforce. And also, kind of look into return on investments by, increasing a lot of preventative health. How can these providers who may somehow work in a clinics or other places that can really help improve, health outcome. And also, increasing cultural and linguistically access to these various providers that, work in different settings and different community spaces that THWs align with. And so that was another thing that these are three, and there were more other elements related to that I just wanted to kind of list here, but there is also available in our website with some information of why 2.0 created and what was the intended outcome that we wanted to foresee, that we see a shift and a change in the system itself. If you can go next slide, please. So a typical example I wanted to share here is, and I think like many others have shared, is as all of you know, among the various THW workforce, there are like different sets of systems that we have in place with, for example, with managed care organization. As all of you know, doulas are like one of the growing workforce in Oregon. 6 years ago, we had about like statewide, we had about 40 registered, doulas. Now we have over 160 doulas that are like practitioners in the state that provide, doula support. And you could all see and attest, the previous literature, like Sam has shared, that when it comes to, a little bit in terms of improving even more doula access to really change the state's maternal child health outcome and where we are when we compare to other states. One of the big things that we really, Oregon became a little bit with a shortfall is the payment side of it. Currently, we use the state, fee-for-service rate, which is about $350 is what we pay for doulas. And I think particularly this is for fee-for-service. And then as a result, some of our managed care organization tends to use the state's rate as a place to start with when it comes to paying for services. And as a result of that, there's a lot of inequities when it comes to payments. And so this has resulted not many doula providers who can really change a shift in terms of, maternal child health outcome impacts in the state. I'm not seeing this as a more rigorous, employment, because, you cannot sustain and keep an employment with, few, pregnancies here and there you take as a THW doula, when that in itself does not earn you a whole lot of money. And so with that in mind, there are a lot of movements happening, but again, in our managed care organizations or CCOs, there's various payments that is sometimes provided. Some will pay within $1,500, some may pay $1,000. It kind of varies across the different, spectrum. But one of the big push we've been working internally within OHA is figuring out if we can bump up the payment rate that the state currently pays, which may trigger, other elements that we have to do in terms of state plan amendment, other things. But in the end, is to really move from $350 to maybe a more, sustainable, but a little bit supportive, rate that can really help. And if we can shift our managed care or CCOs towards that form of a payment, so then we can increase more mothers and more, members of the community to have a lot of access to doulas. But this is a typical example that I want to kind of highlight and share, what more clinical integration may look like. Yeah, you can go to the next slide, please.
So sorry, Mohammed, if you could take a minute or two to wrap up.
Sure. So my last finding here I want to kind of mention is 2.0, which is about where are we? So we tend to see a whole shift, and all of you, and I wouldn't be able to talk in depth here, but I will, I'll be happy to answer a lot of questions later, but this is mostly about where are we today? So we have seen a shift in terms of payment-wise from our coordinated care organizations. There's a lot of movement in terms of when we talk about, some challenges within our CCOs, FQHC, and other behavioral health organizations. And also there's a little bit, a lot of moving pieces that when we talk about CCOs and how they are supporting the THW workforce, but we are not there yet, but there's a lot of work that needs to happen. And this is basically informed and shaped by the kind of, contract deliverables that CCOs submit around what kind of payments they pay in terms of THW workforce. So if you can go next slide, please. And these are some typical examples that exist today. And this data comes from a preliminary data that we received when CCOs first submitted their payment great that they pay for THW workforce as a CCO within their CCOs. And these are like some typical examples that you see here when we talk about various alternative payments method that exist, that a lot of CCOs use in different sectors of the state as well in different regions. Next slide, please. And this is another piece around regarding contracting, and various forms of it. And so again, the data I'm sharing here kind of informs of, what do we know from 2020's CCO deliverables when we talk about payments and where are we heading to, although we have a very, much different data in 2021 report, which we are working to analyze and probably release some data around that by the spring, which may help us inform more like, there's a lot of ratio in terms of providers and things like that. So if you can go to the next slide, please.
Oh, I'm sorry, you have the wrong number. Bye-bye.
And so overall, when we talk about generally, we are a bit heading in a good direction with Oregon. So I'm hoping that, when we talk about the work that our CCOs do and the work the state is doing, there's a real hope out there that how do we create a better, more integrative, model of, providing these providers with payments as well as more, service delivery models that can really support, improve, health outcomes and health inequities in the state. Yeah. I may have to jump into another meeting later, but I'll be happy to answer any questions down the road. And my contact information is there as well. And thanks for the opportunity here.
Thank you, Mohammed. And I also just wanted to make sure that the QHOC members noted that the commission had sent a letter at the end of January to really emphasize its interest and willingness to work together across all the different parts of OHA. That obviously THWs are really an important asset that the state has really cultivated and nurtured and grown, as Mohammed noted, in the growth of doulas. And so this is really something that we need the collective energy and wisdom of everyone and experience to move in that journey towards greater integration, utilization, and payment models that are sustainable for the THWs, but also for the CCOs as payers. So thanks so much, Mohammed, for that. In the interest of time, because we are running a little bit behind as often we do, I am going to turn directly to the CCO representatives. Again, we're just hearing from a few of them. Obviously, every CCO, as Mohammed showed, has different ways and strategies for trying to integrate and pay for traditional health workers. But first, let me introduce Iris Bixler from Pacific Source Community Solutions, who is the THW liaison for Pacific Source. So Iris.
Thank you so much, Ignatius, and thank you all for having me today. I think we've got a slide deck here that we're going to start. So my name is Iris Bixler, as Ignatius mentioned. I use she, her pronouns. I am a certified community health worker, peer support specialist, and doula. I'm the traditional health worker liaison for our Pacific Source Lane CCO. Pacific Source has a dynamic team of traditional health worker liaisons, one designated to each of our CCOs to advance regional strategies while we work together within the company internally at the systems level. So I have Nancy, Chad, and Samantha, who we work together with as a team. Next slide. So today I just want to talk briefly about traditional health worker background, who traditional health workers are, the benefits. Fortunately, my colleagues ahead of me were able to really outline that well, so I won't go into too much detail. But I do want to talk a little bit about the role of the liaison, some of the contracts and supports that Pacific Source does, some payment models as we've begun to talk about today, and then just some general takeaways. Next slide. So first, a little background. I just want to level set that our communities have had traditional health workers in some form under some name for centuries. So this is not new work per se. It is new work within Medicaid. So to recognize traditional health workers as a valued part of the healthcare system, in 2011, the Oregon legislature passed HB 3650, which created the structure that allows traditional health workers to become certified through the state and bill Medicaid. The model really is culturally responsive, trauma-informed, and high-quality care to our underserved populations. And it is a health equity strategy to work to address social determinants of health within Pacific Source. Next slide. So the traditional health worker name is an umbrella term for frontline public health workers who work either in community-based or clinical settings. As several folks have mentioned, we have 6 traditional health worker types, including a tribal traditional health worker, which is new as of legislation last year. And the overarching ethos of traditional health workers is that they are trusted individuals from the local community, and they share lived experience with those people that they're working with. Traditional health workers provide one-on-one and community-level support to navigate complex systems, connect to resources, advocate, empower, and be a model of hope and resilience. Next slide. Again, benefits of traditional health workers, as you've heard, reduce health inequities, help build trust, improve access to care and health outcomes, and really advance the quadruple aim. Next slide. So as part of CCO 2.0, the THW liaison role is an OHA contract requirement. We work internally and externally with the overarching goal of increasing member access to traditional health worker services. So we help grow the workforce with workforce development strategies. We support the traditional health worker community. We educate providers on the benefits and best practices of traditional health worker integration. We support traditional health workers to the OHA certification, and we support their understanding of billing Medicaid. We work at the state level, so I myself am on the Traditional Health Worker Commission. We have various places and spaces where we advocate for better systems to improve traditional health worker access. I will say, as the first traditional health worker liaison to be hired in the state back in the summer of 2019, I have unfortunately seen a lot of turnover within this role. So OHA, CCOs, the traditional health worker workforce statewide, I believe really needs to continue to learn how to use this role efficaciously in order to achieve our collective goals and retain the traditional health worker liaison workforce. Next slide. So I did want to highlight some of Pacific Source's traditional health worker strategies. We contract with clinically and community-based organizations in all 4 of our CCO regions. So we contract with 2 large doula hubs, one of which has doulas serving members in 3 of our regions and has been successfully billing since 2020. The other doula hub has a wide demographic of doulas on their roster, including doulas that speak Spanish and Swahili. We've contracted with 7 community-based peer-run organizations in Lane and Marion Polk CCOs, which include services like youth drop-in centers and online recovery support groups. After the traditional health worker liaisons provided some technical assistance to our dental care organizations in 2021, Capital Dental hired 4 community health workers, one of which is working in a tiny dental home on wheels. You should see it, it's really incredible. And that tiny home actually drives around to rural parts of Lane County. To ensure members have access to traditional health workers, Pacific Source has hired 9 OHA certified personal health navigators to be on our care team. We also funded community health workers to provide community specific services, including in Columbia Gorge, where community health workers are supporting COVID positive families, offering postpartum support groups in Spanish, and diabetes education for migrant farm workers. We understand that there is no member access without robust traditional health worker workforce. In 2021, Pacific Source sponsored 2 doula trainings, 1 community health worker training, 2 peer wellness specialist trainings, all to people living or serving our members across the state. We also funded a culturally specific community-based organization in Lane County to develop a bilingual community health worker training, and supported Central Oregon Community College to develop the only OHA-approved community health worker training in Central Oregon. Next slide, please. So how do we pay for traditional health workers? The million-dollar question. Here at Pacific Source, we have three basic payment models: fee-for-service, value-based or capitation arrangements, and alternative payment models. So fee-for-service, OHA has the ability, OHA approved codes for doulas, peers, and community health workers. However, at this time, there are no codes for personal health navigators. Pacific Source did develop a new payment methodology for community health workers in our PCPCHs Tier 3 and above, which is a value-based payment, PM. And we also have a new alternative payment model we call the programmatic payment that we're rolling out this year, specifically to community-based community health workers and peers. Next slide. But there are challenges, as Dr. Savage mentioned. So fee-for-service comes with some restrictions. Does it pay for the whole scope of work? Is it sustainable long-term? All of these things, I would argue, probably not. So we need to find ways to support this work outside of the fee-for-service model. Community-based organizations lack contracting experience. So there's a lot of hand-holding, a lot of walking alongside that we need to do as we're contracting with community-based organizations. Traditional health workers have concerns about Medicaid billing. Is it co-opting their role? Is it putting it a square peg in a round hole? So we really need to be trauma-informed when we're talking about integrating traditional health workers into especially clinical settings. Specifically around doulas, they don't have, as a workforce, the experience of doing any Medicaid billing. So there's, again, a lot of workforce development issues that we need to do to lift up their ability to serve members. Next slide. So there are opportunities. So the liaisons, we're going to continue to support and educate traditional health workers and those who hire them. CCOs and liaisons within them are continuing to advocate to OHA for change, including waivers. At Pacific Source, we have a traditional health worker steering committee and a traditional health worker payment model work group that's strategizing solutions. And we're hoping that OHA continues to develop VVP standards for traditional health worker payment. Next slide. Takeaways. You've heard a lot of information over this last hour, and you're going to hear from my colleague Cliff and Maria as well. But just the overall takeaways here: traditional health workers provide culturally and linguistically specific services to underserved communities. They build trust and engage members in accessing care. Clinically based traditional health workers can support quality metrics. There are challenges and barriers to THW payment and integration, but there is hope. CCOs and OHA can work collaboratively to ensure traditional health worker sustainability and member access. I think the last slide there is my contact information. Please feel free to reach out if you have any questions.
Great. So thanks, Iris. So quick question from Summer, if you can answer, as you're developing and beginning to implement the value-based payment models, in particular, both the PCPCH model as well as the community-based programmatic model, have you decided on which quality measures you're tying those payments to?
There is no quality measure that is tied to the payment. We just believe that community health workers are essential to part of the service array of a PCPCH office. So there is no specific quality metric that we're tying that to.
Okay, great. All right, so thank you so much. Let me then turn to Cliff Juneau, who is the THW liaison for Jackson Care Connect. Cliff?
All right, hello everybody. Thank you so much for having us. And thank you, Iris. She did a great job of talking about the different worker types and doing a lot of the prep work for me. So thank you very much. Next slide, please. So I'm not going to spend a ton of time on this slide, but we're going to revisit it after I go through a couple more slides. The reason I'm showing it now is I just wanted to show the different places that we have traditional health workers right now. So for community health workers, like Iris said, they've been in place for a while now, and we're just starting to get some momentum around it because we're needing to pay for it. So In our clinical settings, Rogue Community Health and La Clinica, both FQHCs, have community health worker programs in place and have for quite a while. So we've had that for quite some time. In the community, we have Mercy Flight's mobile integrated program, and our local YMCA has community health workers on staff, and they're there to help as problems arise. Our peer support specialists in clinical settings, our behavioral health network has peers. Oasis Center of the Rogue Valley is a really interesting clinic working with individuals that have some kind of connection to behavioral health issues, and they have a peer support specialist as well that is cross-certified as a doula. So not only is that peer able to support the patients that are in recovery, now she's able to help pregnant people who are in recovery and help them through that birth process. And we're really excited about the work that's being done there. In the community, Rogue Retreat, I'm going to talk about them later. And then for doulas, we do have a few doulas in clinical settings. The Asante Ashland Hospital and our local Providence Hospital both have doulas on staff. Just mentioned that Oasis also has a doula on staff. And then in the community, we have Rogue Valley Doulas, and that is a doula hub that I will talk about in a few slides. Next slide, please. All right, so why do we fund these services? I think Iris did a great job, and our other presenters have done a great job of talking about that. So won't spend a ton of time, but in clinical settings, it just improves the holistic impact of primary care and behavioral health services. So it really changes our system from looking at specific diseases and specific problems to really looking at whole person health and what that means. We're bringing social determinants of health into healthcare, and by having traditional health workers in those clinical settings, it's highlighting those social determinants of health. And then why are we doing it in the community setting? And it's so exciting to have this happening finally, because many people just don't trust the healthcare delivery systems for a lot of reasons. So by contracting with traditional health worker services in the community, there's no wrong door to get into the healthcare system. And this may be a way for our members to get into the system in a way that we haven't seen done before. For those of our clinics that have traditional health workers, they may not, whatever the program specifics are, may not warrant having traditional health workers in those settings reach out to some of our members. They don't have an A1C that is scaring anyone. They don't have that chronic disease that we're all wanting to help manage in a little bit better way. So by having those traditional health worker services in the community, if somebody is working on their social determinants of health with that staff, they can help those folks get the healthcare services that they need, even though it may not be quite as serious as some other folks. Again, just no wrong door of getting into that healthcare delivery. And then even for the members who have the underlying concerns, clinical concerns, social stability and other social determinants of health may be a bigger priority. It often is a bigger priority. So working with the traditional health workers, again, in the community, lets that happen and take some of that burden away from our primary care providers. So, yep, next slide, please. All right, and so what do they bring to the members' care team? Health literacy is a big thing. For a lot of folks, they may not have used traditional healthcare services in the past. And this is a way of increasing an individual's health literacy. And with that, it is they get more confidence and are better able to voice their own preferences. Hopefully it's going to increase their confidence in their treatment plan because they, again, are voicing what it is that they want or think they need. And hopefully it's an increase in overall well-being and overall health. That's the goal of these programs. And so some of the ways that we might save some money are decreased costs associated with deferred care or inappropriate utilization, improved quality outcomes, again, associated with greater health literacy. And one of the things that JCC and Care Oregon are really wanting to address is the health inequities within our communities through the use of our traditional health workers in the community. All right, next slide. So for this, it's just, I'm going to talk about the guiding principles for our program rather than getting into some of the specifics. You know, what are the guiding principles? And like I said on the last slide, it's really improve the health outcomes through health equity. And so filling gaps in care coordination services that can't be filled through clinic-based services. And some of our CCO care coordination services can't be done as effectively. So it's people boots on the ground doing the in-reach into the communities that have traditionally had inequities in place. Sustainability, we believe that traditional health workers ought to make a living wage, and that is a big part of our payment methodology. So as we're thinking about the contracts that we have with our community-based organizations, we're thinking very hard on how to support the workers themselves in higher wages and the organizations themselves to support the workers with those higher wages. And then really being transparent and accessible in the way that we're contracting with our CDOs. We want them to know why we're asking them to do certain things. And we also want to be hearing from them so that if we need to scale payments or payment approach in a different way, we can do that quickly. So really shooting for the transparency from both sides. Okay, next slide.
So sorry, Cliff, we're running out of time. So you could just take another minute or so. Perfect. So I will talk about Rogue Valley doulas because I think it's our best example at the moment of our quest for equity. So Rogue Valley doulas has a few doulas on staff, or it's a doula hub, so they are supporting doulas doing their work. But Rogue Valley Doulas is starting a doula training program, and it's specifically for bicultural, bilingual folks. And JCC is supporting the creation of that training. And after those folks get their training, after we have bilingual, bicultural doulas trained and ready to go, they will be able to support JCC members. So really excited for that. And that's how we're reaching out. And I think there's just one last slide.
Turn right onto Northwest 235
I'm just going to skip that one and go directly to the next one. So recommendations, training issues, we're working with state, like Iris said.
So sorry if everybody could mute. Huberta, could you mute yourself, please?
All right, thank you. So we're working with the Office of Equity and Inclusion with a traditional health worker liaison work group. So some of these recommendations have already been implemented. We have a ways to go, but we are making progress. And then my last slide is my contact information. Please feel free to reach out if you've got any questions beyond this. All right, thank you.
Great, thank you so much, Cliff, and sorry about rushing you. I want to get to our last presenter, Maria Tafoya, who is the Equity, Diversity, and Inclusion Manager at HealthShare, and is going to talk a little bit about traditional health workers at HealthShare.
Thank you, Ignatia. So good afternoon, everyone. My name is Maria Tafoya. I use she, her, ella pronouns. I'll be short and sweet. Maybe that's why Ignatius put me last, because it's very short and sweet, to the point, and really wrapping up a lot of the incredible talking points that my colleagues and others have presented in terms of our THW liaison work. Go ahead on the next slide. Great, thank you. So for today, I will be talking really briefly, sharing what is our collective vision here at HealthShare. I will be also sharing our payment grid and a little bit of connecting the dots for you in terms of quality metrics and some of the work that we are doing here. But before that, really wanted to share our collective vision and kind of our why behind some of this work. And just whoever's doing the slides, I have a lot of animation in my slides, so you can click on the other, or click one more. Beautiful, and one more. So as HealthShare, kind of our approach has been or our goal and our vision for this work is that members have access to THWs of their choice in a setting they thrive in. THWs are honored and respected by the health systems for serving marginalized communities that ultimately help them reach their highest health outcomes. And how we're thinking about doing this work in our approach is that this will be accomplished by reconstruction of health systems, its policies, and funding mechanisms that honor THWs. And really this is, again, with health equity at its end goal and reality for all of our members. Below in this graphic, you'll see kind of our 4 goals that are very much in alignment and in connection with our CCO 2.0 requirements around our deliverables for this THW work. And so those 4 goals are around, as you've hear from the other THW liaisons, is establishing funding mechanisms, increasing number and access of THWs, increased integration and support of THWs in the health systems, and from us as HealthShare, having a clear leadership and advocacy model. So also what we're doing here today in terms of sharing our own experience and our own journey, is lifting that alignment and making sure that we're sharing kind of what we have learned and in our story as well. Go ahead on the next slide. So HealthShare's THW payment grid, as Mohammed mentioned, all CCOs are required to submit a THW payment grid. So I'll just give you a quick overview of what we've submitted for last year's 2021 THW payment grid. Go ahead and click next. So in our 2021 THW payment grid, we reported a total of 601 FTE that were reported by HealthShare partners. This was a 41% increase from 2020. One thing to note though is that 2020 was the first year that we CCOs were required to start collecting some of these numbers. So either we got really better or really good at collecting information, and that's why we have the 41%, or we saw an increase of this workforce across our systems. And in terms of that little visual there is that 83% of the FTE reported was attributed to community health workers as 42%, and peer support specialists was our two largest THW worker types. We do have some patient health navigators, peer wellness specialists, and doulas. We can always do better. Go ahead on the next slide. Or not the next slide, the next click. No, go back. Again, an animation trying to make it interactive for you all. So how does HealthShare pay for THW? So again, they vary depending on worker type. You've heard, some experiences in terms of, having some codes for peer support specialists, even for community health workers. But there's also realities and challenges, right? We're asking a THW workforce at times to figure out how to, manage the billing system and figure out, particularly within community-based THWs, and that's something that there's not an infrastructure for all of the THW types. And so THW payments vary. So alternative payment model, grants, direct employment, fee for service, and contracting contracting primarily with clinics is one of the largest ways that we're paying for THWs. And I didn't include the other graph because I'm like, oh, we only have 10 minutes. So go ahead on the next slide. Go ahead, click next. Next. So really wanting to align quality metrics, THWs, you've heard a lot of words such as essential, crucial, needed in terms of addressing quality metrics. And if those are some of the words that you can take on as you're bringing back what you've learned today, this workforce is essential and crucial in building those quality metrics and supporting those quality metrics. So think of it as your partners on the ground and workforce. They are, as Iris mentioned, valued community, trusted community members. They are centered on relationship and health promotion and community wellness. Click on the next. In terms of the health system partnership, go ahead, click next. It's a person-centered approach, right? We're thinking about culture, about trauma-informed care. Partnering with traditional health workers are key and instrumental in supporting your goals around that. In terms of addressing health equity, racial equity, this workforce is oftentimes culturally and linguistically diverse as well. Go ahead, click next. And I'll just share briefly, go ahead, click next. That as an example, we at HealthShare in our transformational quality strategy and our performance improvement project, we are focusing on two THW types, which is doulas and peers. For our doulas, we are doing an intentional racial equity work in terms of addressing disparities within our pregnant individuals that identify as Black, African American, and start building some ratios in terms of some goals and targets that we can work towards in addressing within our TQS. And peers as well, again, that culturally and linguistically diverse workforce and building that for our community. So I think I will leave it at that. I didn't include my contact information, but I will include it in the chat. If you have more questions or wanting to know a little bit more of what we are doing here at HealthShare. I know Dr. Kat Livingston, Graham, and others are participating, and they're very much engaged and aware of some of our work around THWs around here at HealthShare. So I'll leave it at that.
Thank you, Maria, and thank you for catching us up in terms of time. So we have a few minutes left, and I encourage people to type in questions that they have. I do want to lift up from our CCO presenters, really emphasizing beyond the clinical setting, a whole range of different kinds of ways in which traditional health workers are engaged in community settings. And so I think that's part of the complicated pathway forward, is really balancing and not limiting traditional health workers to clinical practices and clinics, but really thinking about how THWs can really be assets in the communities where they are, the in-reach, the outreach that they do. And then I think our CCO presenters also really emphasize this is a long-term developmental process. And so it was really important, I think, to highlight, Health Chair is really making a commitment to try to develop the doula workforce in its service area, where in other places the doula workforce is very strong. And I asked Iris to put in a definition of what a doula hub is. And so again, this is a long-term process of identifying, training, certifying, and then supporting doulas. And so that's also a process that the CCOs can be part of, but also is going to take time and resources and investments as well. And then the final thing that I wanted to lift up was just as we are really obviously concerned about whatever payment model being implemented is feasible and makes sense for the CCOs, that Cliff and others really highlighted that we also have to think about it from the workforce of the THWs themselves, and needing to make sure that those models are sustainable and result in living wages for the THWs, so that we don't perpetuate the inequities structurally by using workforce members in which we're not honoring their needs as well. And so that's a complicated part of the puzzle, but I think it's also something that has been really highlighted in this presentation. So hopefully we covered the evidence, what OHA is doing to try to support THWs, and then some on-the-ground experiences of CHWs, doulas, peer support specialists, peer navigators. We don't quite have tribal health workers yet, and we're looking forward to that new worker type coming online, and really understanding the assets and the strengths that they bring to improving health quality and health outcomes for Oregonians. So folks have shared the evaluation form. If you can click on that, it's great to see that most folks stayed. And I will turn it back to Dr. Mountainer.
Thank you. And thanks to all our speakers for a really informative session. Also a reminder that there are the complexities of billing that we still need to work out in order to be able to put the values and principles of equity into action in our incredibly complex medical and health care system, understanding that the drivers of all of these things are not drivers that we are well suited to meet and manage in an exam room. And these are resources in the community that can not only help us address some of those concerns, but do it in a culturally responsive and honoring way that can help us perhaps do better for those communities that we have struggled to support very well over the course of this pandemic and before, and long before that. So thank you everyone for your participation. Please do provide us some feedback so we can keep getting better at giving you the content that you need and want in these sessions. And to our speakers and Ignatius, our facilitator, thank you so much for coming together. Thanks everybody. Have a great day. Happy Valentine's Day.
Bye, Don.